Emily back for video 2 of our series on concussion. In this video I want to focus on some of the myths, the commonly held myths about concussion, and just really tell you some interesting facts. First of all, we as clinicians hear things from our patients all the time, especially when related to their concussion, like, well, I didn't lose consciousness, or I don't think a concussion is a brain injury, or, my symptoms should resolve in about a week. These are really commonly held myths, but they can be quite damaging. And in fact, there's a lot of research out there to show that when institutions and communities made a concerted effort to raise awareness about concussion, that the people in the community had higher reporting rates of concussion, higher treatment rates, and quicker treatment rates. So that really does show us that marketing about concussion works. The next myth I wanted to talk about, or the next misconception I wanted to talk about, is concussion in the military. In a study in 2018, it was reported that up to 50% of concussions go unreported in the military. That is a huge number. Especially when we think about what is happening in concussion. We know we have the dizziness and the visual impairment and the headache and migraine, and the fact that up to 50% of people aren't reporting it or getting help for those treatments, well, you can see how big of a problem that would be. And then related to those military statistics, there was a study done that compared the different types of concussion and how they both experience dizziness. So blast concussion or blast related concussion is when a person sustains a concussion from a blast injury. So something goes off and they get thrown. Blunt concussion is when someone is hit on the head or gets concussion from trauma directly to the head. So in this study, it showed that although both types of injuries had dizziness, the dizziness that they reported was actually really different. So let me have a look at these numbers here. Blunt mTBI, blunt concussion, so that's where there was a hit to the head, reported migraine in 59% of cases. And they also reported dizziness related to exercise, so exercise-induced dizziness in 6% of cases. However, blast-related TBI, they reported migraine in only 29% of cases compared to 59%, and they reported exercise-induced dizziness in 24% of cases. So you can see that the type of concussion you get will actually have different presentations, or the dizziness can be coming from different sources. So that's just, I thought, really interesting, that you can, knowing a little bit more about the pathology or the mechanism of injury might steer your thinking, might steer your clinical reasoning as to what you're going to do next. And the last myth that I wanted to talk about is in relation to headache and the role that a therapist can play in treating headache. Now, Joe goes into detail in the course with regard to goals, plan of care, treatment strategies, interventions that you can implement to target headache. But this is something that a lot of clinicians don't know that they can include in their plan of care, or they don't really know how. So I just wanted to go over some of the goals that you might find yourself setting if you are working with someone with post-traumatic headache, post-traumatic migraine, or concussion-related headache. You might have goals like, if they have migraine, your patient will become independent with trigger awareness using their migraine journal. You may say that the person will tolerate computer stimulation for up to 4 hours with minimal headache complaints, or that they'll achieve independence with stress management activities, or that they will achieve 2 to 3 hours of IADL with minimal headache complaints, or less than 3 out of 10 on the visual analog scale. These are the types of goals that you might find yourself setting. And then the treatment strategies or the therapeutic interventions that you might be using are things like helping them identify migraine triggers, modifying tasks, stress management, doing HEPs, mindfulness, yoga, or cognitive behavioral therapy, which can be very, very effective, and medication management, and so on. So this is all to say that the role of the therapist with headache and the pain related to post-traumatic headache can be a vital one. So as before, I linked to one of our resources on this down below, and also check out the link for more information if you're interested in learning more about the course and getting this education into your clinical toolbox. You can always contact us, info@arcseminars.net, and I look forward to hearing from you all.